So I'm Mikhail Prokopenko. I'm a professor at the University of Sydney, director for the Center for Complex Systems, and School of Computer Science is my home school. I do work together with epidemiologists and public health experts in the Sydney Institute for Infectious Diseases. So this third affiliation is quite relevant for this particular talk. So I will talk about socioeconomic part of the pandemic modeling, and hence the title Health versus Economy, a False Choice. It's been argued for many years that there is some sort of tendency to put one aspect over another. For example, the first lockdowns which were imposed early in the pandemic in 2020 and even in 2021, not only in Australia, all over the world, have been criticized by the hardliners in terms of the economic costs that society incurs, and vice versa. People who want to focus only on the cost of the pandemic have been criticized because they seemingly ignore the value of human life or years of lives lost as counted by some economic health economics. So it's been, as you know, very vigorous debate over the last years whether one side or another is more important. And I will argue in this talk that this choice is actually a false choice. We could do a meaningful, balanced optimization in managing these two aspects of the problem. And hopefully I will argue, I will demonstrate that the outcome of such optimization is quite a balanced choice, right? So we don't have to choose either or. There is some sort of a balance in between. And at the end of the talk, I will still talk about inequality that pandemic response imposes on the communities, on people, on individuals, and different local government areas unequally, dependent on variants, dependent on policies, interventions, and so on and so forth. So although there is a way to balance health and economy, we still need to do it in a careful way so that the burden carried out by different communities and vulnerable individuals is taken into account in our response. So without any further ado, I will move into sources of complexity. And these three underlying sources will be quite visible in the models that we have been using. Obviously, there is a biocomplexity starting from the bottom here. We're dealing with the emerging virus. We don't know what it is. To begin with, we need to deal with evolutionary aspects of this new virus, emergence of subvariants, sublineages, and so on and so forth. So it's complex in that sense. But it spreads, the disease is spreading in socium, and human behavior affects it quite badly. I'm not talking only about mobility of people who may spread this disease rapidly over long distances because of the travel. I'm also talking about behavioral aspects, and human behavior is very complex. So we cannot focus only on the biological transmission aspects. We need to think about what can be done in terms of modeling human behavior. In this talk, though, I will also focus on socioeconomic complexity, because the problem we are trying to solve here is how this social costs are actually impacting economy. Because we don't live in a vacuum, and we could obviously go with a full lockdown and try to eradicate, eliminate the disease. But if the economic cost is completely beyond belief, in that case, we need to think twice whether this is, in fact, not a near-sighted solution. Usually, though, it goes the other way. People try to avoid major economic costs, and that becomes near-sighted solution, because human life is not valued adequately. So these three sources of complexity are underlying reasons why even after 4 years of pandemic, COVID-19 pandemic, or even 100 years plus since Spanish flu, we don't have a recipe how to deal with it, how to value a year of life lost, disability adjusted or not, how to advise the governments, how to deal with the social discontent, if not rioting. I mean, people seem not to get the idea or have some sort of fatigue with all these interventions. We don't seem to have, some kind of rule book which could say, okay, year 1 you do such and such things, year 2 maybe switch to vaccination, year 3 start to relax perhaps. We keep rediscovering these common sense behaviors in a painful way. So that's what I'm trying to use as motivation for this modeling work. So just to put it in context, because most of this is done in Australian setup, and obviously I could turn it into cases per million to start comparing in a meaningful way. But my point here is to give a qualitative picture of how these waves of the COVID-19 pandemic developed in Australia since the very first days. When we look at end of February 2020, the first wave, which was quite profound in making an impact on Australia, pales in comparison, right? This is logarithmic scale, and you see a few orders of magnitude between the first wave and the third wave. That one actually is a delta wave, the third wave. And then that one pales in comparison relative to Omicron stage, which had a few recurrent waves in January 2022, when we hit 150,000 cases a day. I'm talking incidents, right? A day. But in terms of shaking the human confidence, the first wave was quite bad because people didn't know what we deal with. It was a novel coronavirus, and lots of conspiracy theories were circulating, and people were really panicking. The second wave was mostly developing in one of the states in Victoria, and it is comparable. It was still ancestral strain, Wuhan strain. And then we pretty much eliminated the disease. You see, this is single digits for all of Australia. That pretty much you could ignore that as noise for quite a while until June 2021, when it was traced to a specific limousine driver who didn't follow some specific measures, like mask wearing, and was transporting a cargo crew of one of the trans-Pacific flights, which brought Delta in Australia. I'm not saying it was avoidable, it probably would have happened anyway, but you see from one index case, it grew in a couple of months to thousands of cases per day, and never really got eliminated. It did go down a little bit, and then Omicron came and pretty much replaced Delta. So that's just in the context. So that's what we've been dealing with in Australia. And to put now the economic costs in comparison to this epidemic profile, during the first wave here, there was a full lockdown, pretty much school closed, and everybody was trying to sit at home except essential workers. In Victoria, it lasted like 5 months, again, full lockdown. The Delta started with some, measures which were half-baked and not really wholehearted, and that's why it wasn't suppressed. But we, in fact, estimated that it needed to be, in terms of staying at home orders compliance, it had to be at the level of, say, 70–80%. And it was simply not feasible. It was simply not feasible to do at the time. And that's why it lasted in parallel, the lockdown lasted in parallel with the vaccination, which was beginning to be available. So by that time, 2/3 of the population were vaccinated, at least with one dose, Pfizer and AstraZeneca, and that brought it down. But then Omicron came. So the costs were quite large. We're talking about, say, 1.3 billion Australian dollars a week. So imagine that this goes like for 5 months, 1 billion a week. Same here, 1.4, 1.5 billion a week. So at the time when Omicron started to hit it, people were already saying, let's learn to live with the virus because the economy cannot simply support that amount of cost. And people were losing their income as well. So this is quite a dramatic story, and I'm sure people will look back at this particular tribulation, 3-4 years of 2020 plus, and see that as a case study how societies were not able to deal with it. Yeah. It's the cost of lockdown itself that the economy pauses and doesn't produce, including construction sector, pretty much everything else. The cost of vaccination in comparison was fairly low. It was really like $1-2 billion per campaign. I'm talking about mass vaccination campaign of 95% of Australians. I mean, booster added a little bit, but you know, 1 billion for the whole vaccination campaign in comparison to 1.5 billion a week. It really not major cost. But this is only the incidence. If we look at, say, the deaths, the same period, the same waves, you can see that obviously mortality follows the first wave and the second wave, but those are single digits more or less here. Interestingly, the Delta was managed very well, but when Omicron was allowed to go, it pretty much continued. That goes until the January of this year. The mortality never gone down that much, right? So let's pay attention to that as well. Although the cases going back here, the cases was like incidence was like that, essentially dropping an order of magnitude, if not 2 orders of magnitude, right? Logarithmic scale. The mortality pretty much stayed like that, yeah, like this. So, okay, so that was just motivation, and I just want to move on to the actual modeling exercise. I think yesterday I did cover most of this methodological approach. I think most of you have been there yesterday, right? So, okay, good. Just for completeness, I have some of the slides, but I will not go through nitty-gritty details. The agent-based model includes 24 million agents matching Australian population, so calibrated to census, an agent per individual, in characterizing demographical distributions, mobility patterns, and the disease itself. I mentioned all the stages, and pretty much we were modeling and calibrating to different waves and stages of this pandemic, so with some relatively small adjustments to the transmission model. So each agent has attributes in terms of residential and working mixing contexts. Importantly, we are talking about compliance behaviors in terms of case isolation, if the case is detected, home quarantine, school closures, and social distancing. So this abbreviation here stands for case isolation, home quarantine, school closures, and social distancing. So importantly, I think that's what quite important to note, the success of this model, and it was one of the better models in Australia for sure, was representation of the household composition. So it was not full connectivity. We're not dealing with a complete graph. It's not even a network model. So household composition has a lot of demographical characteristics, and it varies across different local areas. In some areas you could have a lot of large households with multi-generational families and local government area, you may have, nuclear families with 2 adults and maybe a few children in between on the street. So representing that heterogeneously was one of the strengths of the model. Then the long distance travel versus short distance travel is also an important feature here, especially when you talk about working in the areas which have particular demographic slice and living somewhere else, and vice versa. For example, a lot of essential workers which were allowed to travel even during the lockdown live in those high density areas, but they work in more affluent suburbs. So this interesting commute was a feature which many models try to represent later on, but here you take it for granted because census already has this data. All you need is to generate your artificial agents to match it. In terms of the disease modeling, this transmission was serious in the first because the attack rates on children were fairly low. We are talking single digits, like 2-3%. The first studies in South Korea, Japan, China were showing single digits, while in flu it would be going into the highest demographics, but children would be the highest demographics in terms of the attack rate. So how do you model it, right? So if you don't have age dependence in your model, pretty much it's out of the window. So here we had quite a few parameters which were set differently for children and adults, particularly symptomatic ratios, because usually you set in all this influenza or influenza-like illnesses, you say, okay, 2/3 of population is going to show symptoms. And it's important for transmission because symptomatic transmission is 3 times, 4 times as high as asymptomatic. So if you set this ratio, how many people are symptomatic incorrectly, all of it goes out of the window. So even in Ferguson model, who was one of the first in agent-based modeling world for UK and even Europe, even in that model, it was 67% of all population symptomatic. Off you go. It would not reproduce the children attack rate by any account. So we had to decouple it and set symptomatic ratio for children to be 1/5 and later 2/5 for Delta relative to adults. That was one of the key differences. Then vaccination in 2021 was a major addition to NPIs. So going beyond NPIs to pharmaceutical interventions. And again, we all dealt with single numbers. So Pfizer 0.9, AstraZeneca 0.75 efficacy. You put it in the model, and it starts to be fairly unbalanced and uncalibrated because it's almost like you stop the disease, and it doesn't in real world. So that particular split into 3 components was another insight. I think people in Warwick came up with this idea first, and we followed it fairly quickly. So it has to be split in multiple components, this efficacy, because it's totally different numbers. You could be protected in terms of, reducing susceptibility, maybe 60-70%, but it doesn't mean that even if you are protected, that you are not a carrier and would not transmit it further up. So the transmission reducing efficacy is a totally different number. Could be 0.4, could be 0.3. And even if you get infected yourself, you may not develop symptoms. So symptom or disease reducing efficacy is another number. So those are the features, and I'm pretty much going through for completeness, but I will pretty much go further. That I showed yesterday. It's showing just granularity of the modeling in terms of residential areas, so destination zones, mapping from one to another, so simulating interactions where people live. once a simulated day and where people work once in a simulated day. So this is kind of a bipartite network in a sense, but I want to avoid an impression saying that it's a network, because it's not a network-based model. That I didn't show yesterday. In terms of travel to work data, mobility, that's what the census distribution sort of gives you. It's a histogram how many commuters you have over different bins of distance for students and for workers. So these distributions are quite important to maintain. And when we generate our agents, we try to assign agents to households and to working areas so that this particular profile is maintained, right? It's retained, which is not a trivial exercise. But anyway, so you also have then air traffic, which is much simpler than the demographics, because here you really have incoming passengers for major airports. And since you model pandemic and not epidemic, you need to basically seed your scenarios from all these major airports. So that was pretty much an easy exercise, making your initial infections appearing in proportion to the number that you see here on the screen of international passengers. So the transmission itself is pretty much straightforward, and it's mitigated by the behaviors that I mentioned, case isolation or home quarantine or social distancing. So if people stay at home, they reduce their interactions in the community or workplace. All these numbers could be variable, and those numbers become the multipliers for the transition rates per cycle from infected to susceptible on either side. So for an infectious agent, you reduce it, and if a susceptible agent, you reduce it, because they all reduce their interactions. Okay, so I talked about these free vaccination components. One interesting point I want to bring to your attention is that when you have a published vaccine efficacy from, say, a trial, the vaccine efficacy in terms of reducing susceptibility, VES, and reducing your symptoms, preventing disease, are in fact combined in this 7 minus 0.49 give you something like that, which is sort of Pfizer, and this is sort of AstraZeneca. So you see that these components are fairly lower in their efficacy in order to combine into the clinical efficacy. So this formula is derivable, right? I mean, this is not approximation. So it's on using Bayesian inference. The transmission
it's communicated by the pharmaceutical company.
Only the left column is communicated by the pharmaceutical company. How is it split? You don't know. You don't know. It could be in fact completely different. But there is some sort, like in this example, 0.5 and 0.3 could give you something like that. I don't know how to close that one, but because I don't see it here. I don't have it actually on my screen here. Anyway, the transmission limiting efficacy here is another parameter you need to guess. Some of that is reported by subsequent trials. There was a major full population level trial in Israel, if not a trial, but at least mass vaccination. And these numbers we learned from that one. So let me move on to this. No, I think I lost the. Not with the first two. Yeah, it basically just sits by itself. Okay, maybe I can actually move it. So it's totally an estimate. Yeah, it's totally an estimate, and not really seems to be moving in a totally different way to my intuition. Yeah, I'm using a touchpad, but I don't see where the yeah, it's in the corner somewhere. Anyway, maybe I should. I don't know. I can't even. Okay, now I can move at least. So vaccination efficacy brings these equations in the same way. It basically reduces the force of infection. So the probability of transmitting from agent J to agent I is modulated by the distancing behavior and vaccination. So the risk of infection is 1 minus efficacy. There is no magic here. It's traditional formula. So let me move on to what I promised you to. I'll be talking about how to balance health and socioeconomic consequences. The first difficulty is how do you actually objectively quantify the costs that they become comparable, health and economic costs. Because how do you subtract, lives from dollars, right? Which is almost insane question. Then how do you remove the bias created by subjective policymakers is another question, because even if you know how to compare dollars and lives, do you trust politicians to actually make the judgment on that, right? So, and then finally, how do you account for the diversity and demographics and human behavior? So the last point, obviously, you could guess that I will be answering with the ABM approach, agent-based modeling. I really wish that would go away, but so maybe if I stop sharing, maybe it will just disappear or not. No, I can't really get it. Anyway, so let me reshare. So basically what we tried to do, get back to my slide here. So basically what we decided to do, having already developed ABM by that time, that in order to objectively model and quantify the costs, we will use the okay, so something happened, but at least it resolved. No, it didn't. I'll go back here. Sorry about that. So we decided to follow a particular approach, which is based on net health benefit, NHB, which is more or less elegant formula combining the disability adjusted life years or health adjusted life years and the dollars, given some parameterization. I will introduce that in a second. And then a bold step was that we decided to use reinforcement learning or machine learning algorithm to completely eliminate any bias. Basically, we said, okay, given this parameterization, what is the best policy which maximizes the benefit? How would you allocate your social distancing fractions over time so that it just maximizes this benefit? Because some people would argue short and snap lockdowns is the best way to go. Some people would say, okay, let's just, wear masks at 10%, 20% fixed level. Some people would say, okay, let's continue going 70, 80% forever. Right? All these are subjective judgments. And we said, okay, let's see what machine learning algorithms actually do, given some feasible constraints. Obviously, you cannot avoid allowing essential workers, say 20–30% of the population, to constantly go to work. So move on. So basically here, it's a schematic representation of this optimization. And you have an ABM in a loop, in the classical machine learning loop. So here you have observations that you get from this particular simulation. And there is a decision model, which a decision not of any individual agent, but a decision of the government. Somebody who decides to recommend, say, 70% or 50% distancing or partial lockdown, school closures. So this decision is driven by some sort of reinforcement learning algorithm in the classical machine learning architecture, and it produces an action which is the recommendation. In a very simple way, basically your agent-based model runs for however long it should run, produces an observation in terms of how many people get sick, how many people die, what's the cost, and then you take this observation as input, use your neural network, some sort of model, and produce an action for the next week. Say, okay, last week we did 50% lockdown, now we do 70% lockdown. But as you do that, you take the same reward, which is the national health benefit, and you adjust your algorithm. So the algorithm then updates the weights of your neural network, and so next time you do it in a better way. So that to train that network, you need to run it tens of thousands of times until it starts to maximize the utility function, which is the NHB. It's a particular architecture, but it's not unusual. So the objective function of the reward in terms of the reinforcement learning combines the economic costs and the health benefit. And this net health benefit is a particular formula which balances the two. That's what I will show you later on, because that's what drives the system. Everything else is mechanistic. It takes 24 million agents to do what they do, and it takes the neural network to update the weights, but the function which is getting maximized is this one. Yeah. It took us to get one run just of ABM for, say, 20 weeks. That is 3 hours. But to do that whole loop, it was taking us, it would have taken us forever if we stayed with 24 million agents. So in doing that exercise, we actually dropped to 2,500 agents, basically one little town. We could scale it to, and that would take a week or 2 weeks on a supercomputer. So we needed to actually take the cost that I mentioned, 1.3 billion for the whole economy, and proportion it to that little town. So basically, this is a major limitation of this heavy, with tens of hundreds of thousands of training runs. We could scale it now to maybe 25,000 agents, getting maybe, I don't know, a larger town, but it's not going to work for 25 million agents. It's just not. I know some people are trying it elsewhere, and I don't think anybody who published anything has more than like 2,000, 3,000 agents in the loop. Yep.
How did you did this? So this 1.5 billion per week cost. How did you scale it to the side? Because I know that there are allometric issues that bigger cities.
Yeah, I totally accept that, and we scaled it simply by proportion, right? I know what you mean, but by the time you get to a town with 2,500 agents, you already lose quite a lot of subtleties, because the economy, not just economy, but also heterogeneity. Okay, it has some schools, it has some care homes and all of that, but it doesn't represent the whole richness of the country. And but believe me, we tried Greater Sydney with 4 million agents. We tried, just Sydney with 2 million agents. It just hits the ceiling. It just doesn't work. So I want to point out what this NHB is about, and that's quite important. Other metrics exist, but other metrics all have been criticized, like ICR, cost effectiveness ratio. So this is what it says here: willingness to pay. What we don't see here: willingness to pay, WTP, willingness to pay for one disability adjusted life year. So how much do you put on one life year loss? $10,000, $100,000. So this parameter lambda becomes a crucial socium-driven parameter. Some people would argue, and it also depends on the level of income per capita, GDP per capita. Estimates vary between 10K and 100K, and sometimes 200K. And we investigated the range. So it's actually fairly controversial to put that number and argue for it. But if you investigate the range and get some sort of results, it gives you at least some grounding. But this is a parameter that needs to be very carefully analyzed and considered, because that's what drives the conversion, right? Because what you see here is essentially life years averted saved, right? So if you have, say, no social distancing, it's an example with social distancing. If you have no social distancing, that's what your loss is gonna be. In terms of daily adjusted life years, some people just die, and some people get sick, long sick leave and whatnot. So this is lives like deaths, and that's life loss, and that's life disability. Anyway, so that's a number of years that are going to be lost if you do nothing. So no social distancing. If you do social distancing at a particular level, this is just schematic. If you do some intervention, you get obviously fewer. The whole integration between the two is what is the difference of your intervention. That's how many you save, how many lives life years are prevented. For any given week, say week was a unit of our analysis here, from T to T+1, you get that slice. You get that slice between no intervention and some intervention at a particular level of social distance. So this is measured in life years. So what happens here then, you take the cost that the economy suffered in this week, 1.3 billion or whatever, 100 times less, 1,000 times less for this little town, and you divide it by this magical lambda, which is willingness to pay. So if this is, say, 1 million and you divide it by 10,000, then you get 100. That means that the dollars, given that willingness to pay, were converted into 100 life years. And you saved maybe 80, that means negative, or 120, that means positive. So that could actually be positive or negative, dependent on how many life years your policy prevented, minus the cost you incurred, transferred, converted into the life years. It's such a simple formula, but at least it does the trick of comparing uncomparable. But obviously it works because the lambda you put in. So you need to investigate the range of lambdas. So I'll give you some results here. So what we experimented, obviously we experimented with the lambda, and you see here, for example, willingness to pay 10,000 per life year, or the top row is 10,000, and this is 50,000. We also did 100,000. What you see on the left is actually the maximum level of social distancing that you put as a constraint in your reinforcement learning. You could say investigate all possible policies per week, but all below 30% or all below 50% or all below 70%. So now let's compare, for example, let's just look at that particular plot. I just want to explain what an adaptive policy is. So this blue line is essentially what the algorithm, what the reinforcement learning algorithm produced. It basically starts at maximum. No, it's not that it starts at maximum. It learned to start at maximum. We gave no other constraint apart from 30. It could have been any possible zigzag. But it learned that the optimal policy looks like this. And obviously, it's limited by 30%. It cannot go higher. And it still relaxes it a little bit, given this very negligible willingness to pay. If you limit it by 70%, comparing left and right, it learned to start also at 70%, but yet it learned after 3-4 weeks to drop down. It's really a short and snappy lockdown, and then sit somewhere at about 20%. So there was no template given, no profile was given to it as a preferred. It really learned out of all possible per week permutations. If you look at more realistic 50K per life year, and in fact, in Australia, health economists suggest that this is kind of meaningful. Obviously, here, the balance between health and economy shifts more to health, right? Because it's more expensive to lose a life. So even with the 30%, it still sort of declines the compliance level, but not as much as that. So here it relaxed almost to say 20% or 10%, and here it was still around 20%. But with the 70% social distancing compliance, again, even with 50K per life year, a sharp lockdown could still work. 2-3 weeks, and then relaxation to pretty much 10-20% mask wearing. Okay, that's just an illustration what an adaptive policy learned by the machine learning algorithm looks like. Now let's look at what it actually does in terms of net health benefit. So here we plot cumulative NHB, again for these 4 considered cases. That was 30% maximum social distancing, 70%, and willingness to pay was 10K in the top row and 50K in the bottom row. So what do we see here, which is interesting? The adaptive policy, which is basically RL-based, reinforcement learning-based, is contrasted with few usual suspects. Like one usual suspect is just fixed policy, basically fix the level and don't allow it to relax, right? So that fixed level is this kind of purple curve here, and it does reasonably well, almost as good as this blue one, which is reinforcement learning. But here, it actually quite backfired and stayed for most of the duration below 0 net health benefit. It pretty much miserably failed. No SD is basically hardliner. We don't do anything. We live with the virus, right? So that's your kind of bottom line, right? And the other one is random, just, null hypothesis. If you do randomly, maybe you're just going to be as good, right? So what happens with this case? So social distancing is really limited. It's 30%. It's like, what people have done in Scandinavia. It really is protecting vulnerable and whatnot. So this whole left column here. Even in these circumstances, whether you value your life year 10K per daily or 50K per daily, your adaptive policy, the reinforcement learning, is going to be is a winner. It's just that the fixed, let's say, stay at 30 does almost as good. In this case, it does as good. The randomness obviously doesn't win, and 0 gives you 0 benefit. So that's just a baseline. But if you switch to 70% social distancing as your possible limit, essentially you are prepared to do almost full lockdown for at least a while, what happens is actually quite interesting. In the beginning, these are the first 3-4 weeks when it does see the 70%. Remember, when we looked back here, those were the weeks when we stayed at 70%, 60% maybe. So these were the challenging weeks, right? So when we look at this particular point, the blue line, which is eventual winner, it's cumulative, right? So it's not just you need to integrate any further, it's only cumulative. It was staying below baseline, all of them were, which means your net health benefit is negative. You save some lives, but you spend more per life that you save. It's actually bad. But then you start to relax and you still prevent some lives, and the gain is quite dramatic. It still gets to quite significant numbers here, right? And the fixed social distancing did not even break even. It never gotten in positive territory at all. This is again 10,000 per life year. If you value life more, 50K, 100K, obviously they all work fairly well, but the adaptive one with the relaxation still wins quite dramatically. Right? So that was a comparison in terms of net health benefit. Now let me bring it all together and show you a simple heat map in space of these two parameters that we investigated: willingness to pay, that's the lambda, 10, 50, or 10, 50, 100, which I didn't show, and here maximal social distancing level, the limit, 30, 50, and 70. You can see that obviously this is like a loser, right? I mean, if you value each life so badly and you don't do a lot of distancing, the benefit is 29 out of possible 108. Obviously, if you value your lives very, significantly, and you commit a lot of lockdown into doing it, you get maximal net health benefit. But what's interesting is that the middle case is almost like a sweet spot. If you value lives at 50K, at mid-range, and you are prepared to do partial lockdown, 50%, the net health benefit of 98 is comparable to 103, 104, and even 108. So this kind of moderate intervention with the moderate value assigned to life is, in fact, not a bad approach. So that was one interesting outcome. And the other one, yeah. No, we haven't done it again for the computational complexity reason, but it could have shown us maybe some gradations. I don't believe there is anything significantly non-linear here. I don't think there are some any convexities beyond the normal just gradient going like that. There is a sharper jump here. Where exactly it is, maybe it's 30K and maybe 40 SD. This is already fairly pushing resolution of the social distancing compliance that I believe. I don't believe anything less than 10%. The willingness to pay may have given us a little bit more resolution. Yeah. Could be, but yeah. I think it would at best look like almost like a transition behavior and then saturation. What we did look into is this search space analysis, because for the best policy, the one which maximizes it, for the best policy, you can still have multiple sort of while you exploit this policy, you could have multiple experiments. Each dot represents an experiment. You could get multiple balances, and this is quite interesting because let me explain it in terms of the cost versus health effect. You want to be in the bottom right because you want to have cost as little as possible, and you want to save as many dailies as you can. But this region, which is unfortunately covered by this icon, but you could guess what it looks like, is reachable mostly by that particular SDMAX 70% policy. That's all done for 50K, right? And the blue one with the 30K social distance compliance doesn't really easily get there. So what it means is that when you allow the system to operate with a high limit, it can get to the difficult search space subspaces more easily. While if you limit it to 30%, even 50%, it's harder to find the optimum. It's just simply harder. It's not unusual in many machine learning applications that if you give less constraints, it will find an optimum. But here it was still possible to get some, you see, green dots for the 50%, still getting somewhere here. It's just an indication how difficult it is for machine learning to solve. But think in reality, people, decision makers, do not use machine learning. They simply guess, right? Last week we did 70%. Shall we do 60 or stay at 70? So if we have fewer constraints, they're likely yet to find a good balance. That's all I'm saying. So to summarize this part, actually I don't have a summary yet. How am I doing by time? Almost, yeah, okay. So I will then show very quickly something hot off the press, because I prepared the slides even today, having learned that the paper is accepted. So here is, I'll talk about inequality, and this is from Wikipedia. This is inequality of the wealth distribution. Have you heard about Gini index? Yeah, Lawrence curves. So basically you rank individuals on horizontal axis in terms of their income or wealth, like from lowest to highest. And here you, on the vertical, you rank cumulative share of income, how much they contribute. Say the first 10% of people, say here, contribute just 1% of the cumulative wealth. Right? 50% of people contribute maybe here something like 20%. You see, inequality jumps out immediately. And maybe 90% of people contribute or get, in this case, get 70%, which means the last 2-3% contribute the remaining 20% of wealth or income. So the more convex it is, the more unequal the distribution of wealth is in a country. So what Gini index is the basically area between the line of equality and the curve. The larger convexity, the larger this area, the larger the Gini index. That's what economists have been using for many, many years. So what we decided to do, and that's the main novelty of the paper, which we just got accepted, we said, okay, let's take this concept of a Lawrence curve. Lawrence curve is this curve which builds ranking versus cumulative contribution. Why don't we consider Lawrence curve in terms of the pandemic contribution to cumulative incidence rather than wealth or income? So here, the Lawrence curve is basically fraction of the ranked population, but we need to be careful because we here are not going to be talking about individuals, but rather some comparable local government areas normalized. But vertical is fraction of cumulative incidence. So the question is, if you look at the rank, say first 20-30% of the population, and they contributed maybe, I don't know, 10% to cumulative incidence, well, it means somebody else contributed more, right? I mean, if you look at, say, this point, 80% of the population in this curve may have contributed only 50% to the incidence. It means the other 20% were suffering much more. So 80-20, right? So just imagine that the line here, half, 50%, crosses somewhere here. And you make a projection. So all population to the left of that point contributed to the incidence as much as the population on the right of this point. It's not equal. Yes, that's a good question. And what we rank with is local attack rates. So that's how we compute this curve. It's a little bit complicated, but just bear with me a little bit. So each point here, in this case, we have only 2 points, is one local area, another local area, and the third local area. And say the first local area, point X, contributed 40, basically attack rate in this area was 40%. 40% of people, like 40 out of 100, gotten sick. The second area here, local area here, essentially gotten cumulative. It's 76% of people were sick here, out of all people who got. And the third point. It's a little bit complicated to explain, but essentially what you're trying to do is you want to normalize it. That's why you need to normalize it by total population to make it comparable to the Lorentz curve in economics way. An individual, a person, is the unit. Because this is not ever going to be continuous. It will always be piecewise. And that's why we want to make it as close as possible to the full granularity. But, and obviously, importantly, you want to compare apples with apples, oranges with oranges. So you get ranking in terms of contribution to what you measure on a vertical, which is cumulative incidence. So how many people, proportion to population, normalized by population, were sick in these areas, and how much we contributed to the cumulative, again, in proportion. So if you get, and I'll show you now some results, if you get some curves, and you could basically compare how it changes across years. So there's one year, 2016, simulated using 2016 census versus simulated using 2021 census. Different variants, ancestral, delta, and Omicron. You could see, for example, immediately that Omicron is so fast, so high transmissible virus that it flattens all inequality. Everybody, everywhere gets it pretty much without anything, right? Without any difference in terms of policies. The policies which are sketched here, policy 1, do nothing. Policy 5 is a full lockdown. And in between, you get only NPIs, only vaccination, or policy 4 is a mixed vaccination. So what does it tell us is that the more stringent the policy is, the more unequal distribution of different areas to the cumulative incidence. For example, look at, say, that point somewhere here, right? So let's look at this point. That's Delta variant 2021 data. 80% of the population contributed 50% of cumulative incidence, which means that the remaining 20% also contribute 50%. So you have a divide in the whole national distribution of geography that 80% versus 20% contributed equally in terms of cumulative incidence. So out of 80% of the population here, half of the national incidents were registered. And then out of 20%. So these ones were definitely disadvantaged in that sense. So basically what it does, it turns the Gini index and the Lorentz curves concept into pandemic severity, and we call it pandemic Lorentz curves. You could compare, for example, here in terms of urban versus rural, continuing with the point. And here, for example, you get the national curve. The red ones are national curves, and the blue ones are essentially regional and rural areas. So these blue ones here are way more convex than urban, which is, you would say fairly close to the line of equality. Not very close, but closer than the blue ones. That already shows to you that pandemic severity was more unequally distributed in rural and regional areas. That's already there. I mean, for ancestral and for Delta, because obviously for Omicron, it did not matter at all. And okay, so here I wanted to show you, where is it? Yeah, basically a little bit on school closures, but maybe that's a little too much and I'd rather not go there. Basically, the point is, and Lawrence curves confirm it, school closures, which was again a controversial contribution to all these NPIs. And some people said our results show that school closures do nothing. And some people say, no, they do a major impact. What happens is that it depends on the variant. For the ancestral strain, there was very little difference between policy 4 and policy 5 with an addition of school closures. And for Omicron, there was little difference. But for the Delta variant, without school closures, you would get 2 orders of magnitude more cases. So basically, there is a particular dependence on the variant in making this decision. So you cannot apply it uniformly. It depends on if the variant spreads too fast, school closures will not really make a major impact. It just, too difficult. If it spreads relatively slowly, it's not going to make an impact because other methods would already solve it. But for some variants like Delta, it could make a drastic addition. Without it, you would not stop it. With it, you would. So that was the final point. And to wrap it up, bringing it back to these challenges I started with, complexity of human behavior, that you get different tipping points and amplifications, and vaccine uptake is uneven. Then socioeconomic complexity, which I spend most of the time talking about, the balance of health and economic costs is very important. And the biological complexity is something I'm concerned we're only beginning to experience, despite all this Delta and Omicron. The game only is beginning with the evolution of sublineages, and who knows what happens there. And it becomes very difficult to deal with, agent-based models because history may matter. Just bear with me for a second. Imagine that your agent differs from other agents in terms of natural infections and vaccine history. So that particular history becomes really important. So unless it averages out in some nice way, it diminishes the value of these individual-based models, unless you can represent it very well, right? So that biocomplexity bites back in that sense. But anyway, so I would probably stop here, and I don't have any more slides apart from usual like source, open source code here and references. Yep.
Okay.
Mm-hmm.
How did you say, based on the outcome of the model, did the authorities in Australia? Did they do the right thing?
It's a very good question, and obviously we discussed it with our community of modelers in Australia many times. I would say, and maybe it's better to go back to the slide with the waves where I started with. It would be fair to say that in the first year, in 2020, during these waves, there was a good agreement between decision makers, politicians, and the population. And Australia did very well. 2020, it was a beautiful, eye-to-eye, hand-in-hand agreement, and it resulted in near elimination of the disease. People were pretty much complying, like 80% compliance, the government made quick decisions, travel restrictions, lockdown, school closures, and in Sydney, 3 months later, people said, "Okay, we're done." Victoria did not follow something, and we had a major 5 months thingy lockdown. And again, people said, "Okay, we sacrificed, but we got our life back." But when it happened in 2021 with the Delta, everybody was fed up. People were fed up, and the government was fed up. They did not want to stop construction industry. They did not want to stop many other, even more essential businesses. And it was going on and on. And another factor which complicated the landscape was that Australian government did not commit a lot of resources early to vaccination. Israel was already vaccinated completely before Australia pretty much started the mass vaccination. There was a big gap. Then the government started at around that time, July, August, to ramp it up. It was about 3% of population vaccinated a week, 3% a week. Imagine, 10 weeks, you get 30%, right? I mean, lockdown was going and you keep vaccinating. So that was fairly challenging. And then Australian government ran out of vaccines. So it was almost ridiculous. We were getting maybe some 100 million doses from Singapore, 100 million doses maybe from Poland, just to keep up with the demand. It was not a well-planned thing. I would give it like 50-50, at least they did something, and solved it after 5 months. In 2022, when Omicron hit, it was pretty much a lost game. No point talking about elimination. It was mostly, let's do booster vaccination to save the vulnerables. In that sense, it was a mixed story, because if you look at this mortality, right? I mean, this is not really a very good, story here. So I don't think vulnerable, like elderly population and vulnerable population, aboriginals, they're really, I need to be careful what I say, but so this living with the virus story should have been done still in a heterogeneous way. It should not have been living with the virus for all, right? And I think it was done more in this way, right? Okay, we're just opening up, we're just relaxing restrictions. So if you need to be protected, you protect yourself. Yeah. Mm-hmm. Mm-hmm. That's a very good question. Let me.
It's not going to make any difference, but for those that you have very.
Mm-hmm. Let me find it here. Basically, I think, yeah, we could look at that one. So basically, it tells us that first of all, it is specific on the variant. I'm not really sharing, am I? I'm not sharing here.
That's a problem for intervention, because in the beginning you don't know what will happen with the specific variant that it will spread.
Yeah, basically, what we're trying to say here is that looking at the Lorentz curve at least raises awareness that you need to be more, how to say, tailoring, customizing your approach in different areas. You cannot expect that the outcomes will be uniformly distributed across all areas. We did a much more sophisticated analysis in this paper, and the analysis pointed out that the areas which experienced highest population growth across years are the ones which will be feeling the burden of a sharp epidemic at the peak. So paying attention to areas which experienced highest growth, and to a lesser extent, but still positively correlated, areas with the largest increase in density. We also looked at large households versus small households, and that was again only for Delta variant. The population living in large households was positively correlated with the increase in pandemic peak. So the main advice to policymakers or public health experts, in this case, Lawrence curves analysis, is that there's no silver bullet. You have to be paying attention to specific areas. And which areas? It's the ones with population growth, population density increase, to some extent, larger households. That's what we learned out of it. But look, it's the first paper which ever deals with pandemic Lawrence curves, so we're only scratching the surface with this advice. I expect many more people just jumping on it and then saying, okay, there is, pandemic Lawrence curve in this sense. Here it was cumulative incidence, but you could build it for mortality, right? How the mortality is distributed, right? Which areas are contributing to cumulative mortality, or God knows what, right?
Is the difference in the trends across the strains of coronavirus, they due to differences in the transmission rates primarily, or is it also mortality rate?
Here it is cumulative incidence, so it's not having mortality. So by exclusion, it would mean that the difference is due to the transmissibility. Other parameters did not change much. In fact, we tried to keep all parameterizations the same, except the incubation period, which we had to, and transmissibility. But the incubation period difference here is like, 5.5 days, 4.4, and 4.4. So not a lot. It's purely R naught. It's purely R naught, because for the Delta, R naught was calibrated to be around 6.2. Ancestral was literally below 3, 2.75. The Omicron R naught was nearly around 18. So it's like 3 times. Which is, many epidemiologists or virusologists did not expect it to be, but that's what it is, right? It's interesting to see, to answer your question, what would it look like in terms of mortality? What would Lawrence curve look for mortality? Because mortality here is lower for Omicron, so I expect it to be quite convex, but we haven't done that yet.
Okay, thank you very much.
Yep. Thank you for the questions and having me.